Assalamu alaikum. This is Muhammad Maher, and today we're gonna talk about the pancreas, or should I say, it's more specifically the endocrine pancreas. But there is no harm in mentioning the exocrine pancreas as well. Um, so before I start this video, as I said before on the in the previous videos, please to please treat this video as a background uh, thing before you study the main course on, I guess, uh, the sheets from the university. You could also treat it as a revision, but don't just like study this. I guess like this whole thing from I guess the video and just like go along with it, because not everything is mentioned and detailed here. It's just like this is more of a summary, a revision, uh like a short thing to like study, to look at before or after, or however you want with this video. It's just like more information that could help you with the I guess the course here. So yeah, let's begin. The pancreas. Obviously, the pancreas. We've all heard about it before. Uh, it lies right under the stomach here. So let's see that this is the stomach. This is obviously like the duodenum here. So the pancreas here uh, has a head, a neck, a body, and a tail, as you can see. And it also has whatever this is, a acinitate or whatever. Some people just call it this whole thing as a head. Regardless, though, it's mainly like head, neck, body, tail, and the stomach is supposed to be like this. So it could be like they could give you like an I guess uh, a question on the exam about which of the following organs is superior to the pancreas, and the answer to that would be uh, the stomach here. More specifically, the body of the pancreas would be the stomach. Uh, Another question that I do remember about the exam, it had something about the spleen. It had something about, hey, which of the following is the closest to the tail of the pancreas? It would be the spleen. Even like it says that the tail kind of like tickles the spleen as like some sort of like, I guess, just a way to describe it, I guess. So the tail of the pancreas tickles the spleen, while the duodenum here hugs the head of the spleen of the sorry, the pancreas. Yeah, it's basically that simple. You also have the pancreatic duct. So what is the pancreatic duct? It's basically like a duct that is like connected to the mostly all the head, the neck, and part of the body. It doesn't connect to the tail. And I'll explain this part in a minute. So this duct is mainly it's always just like for the exocrine. Hello Spirit uses like uh, chemicals, and I'm not gonna mention to the duodenum here, so it can help like digest the food here after it's became like a cecum or something like that. Regardless, as I said, this I think like this the pancreatic duct here opens into the second part of the duodenum, or the ascending part of the duodenum, as far as I can remember. Regardless, this is not important here. So, why doesn't the pancreatic duct here reaches the tail? Well, it's mainly because the tail here is the endocrine part. It has all the alpha, beta, and sorry, that's not alpha. This is alpha. This is beta and I guess delta gamma cells here that produces insulin, uh, glu- glycogen, not glycogen. I guess all the hormones. We're gonna talk about this later on, but just so you know, 80% of the pancreas is exocrine, while only 2% is endocrine, and it's mainly located on the tail and the body, half of the body and mainly the tail, all of the tail here. It doesn't have a pancreatic duct. It doesn't reach it because it doesn't need it. It only like reaches secretes into I guess the blood here, which is basically the definition of endocrine. Endocrine basically any gland that secretes into the blood. That's what separates it from exocrine here. Moving on here next. Okay, so exocrine, as we said, reduces pancreatic juice, which helps break down the food, sugar, fat, uh, starch, or whatever. The endocrine here reduces insulin, glucagon, and somatostatin. 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 More on that later, though. I'm going to talk about it later. So the lies mostly posterior to the stomach. Mostly posterior to the stomach. Yeah, that's true. It tracks the it tickles the spleen, as I said. It's its neck makes the start of the. Oh yeah, that is very important actually. The portal vein. So you probably can't see it here, but or maybe like you could imagine, you can imagine. But basically, the vein, the portal vein. What is the portal vein? Portal vein is basically like you have like the intestines here. Should be like something like this. This is like the ileum goes like this, and it has like veins, right? Veins go up and up, and as soon as it passes, by the way, it passes like behind the pancreas here. As soon as it passes the neck part, it's gonna be called the portal vein. It's gonna be called the portal vein. So it marks the point where you call the vein here a portal vein, which goes back to the liver here, the liver, and yeah, complete the process here. Um, the head is hugged by the duodenum, as we said. The tail and half of its body is anterior to the left kidney. Oh, okay, that's I guess important. So at what level on the I guess the vertebra is the pancreas? It would be from L1 to L2, uh, and it's supplied. So basically, the body here, as you can see, uh, and the tail is supplied by the splenic artery. So obviously, the splenic artery is like it looks like this. It's like it's not straight. It's just like moving up and down like that, and it's separated from the uh, celiac trunk here. It mainly supplies the spleen here, but it also have like some little like I guess arteries that supplies the body and the tail of the pancreas here. This is like the main blood supply here. And sorry, is that superior mesenteric artery? This is the superior mesenteric artery. It kind of like passes through the neck here. The aorta is here. Okay. The splenic artery supplies the superior part of the pancreas. So it supplies only this part. As far as I can remember here, only this part. The head is supplied via the gastroduodenal artery. I haven't drawn it here. Maybe it's not like I can't remember exactly where, but it's mainly supplied by gastroduodenal artery here. Uh, well, it is supplied mesenteric artery supplies in the inferior part of the pancreas. mesenteric artery. So the mesenteric artery, superior mesenteric artery, this artery supplies the inferior part of the spleen here, as you can see. So let's talk more about the endocrine of the pancreas. So as we said before, the main tail and body has beta, alpha, delta, and gamma cells, right? We're just gonna focus on the beta, alpha, and delta cells here because they're the most important here. So, what makes the majority of the cells here is the beta cells, and they are the one that produces insulin, which is the most important, I guess, hormone that is being produced there. Yeah, it's right there. Like, this is like the islets, like a microscopical thing here. I guess this is the beta cells, and it's surrounded by alpha cells. And what does the alpha cell do? It produces glucagon. We're gonna talk about the functions of these cells later on. Uh, but as we said, like there's like four types of cells: alpha, beta, gamma. Uh, and I remember, I also remember something about like it was like a question on the final exam. It said something about which of the following cells in the pancreas, in the endocrine pancreas, makes the majority, uh, or which one of the following makes the majority of the endocrine pancreas cells, and that would be the beta cells, uh, which is 65% of the total cells in the endocrine pancreas. We're gonna more talk about the delta cells here. So it's also known as delta cells and makes somatostatins. Uh, yeah, it's metastasis. I don't know exactly the function behind it, but it's not that important. You just focus on the glucagon and the insulin here. So the insulin. What does the insulin do? I'm pretty sure that most of you guys know. Sorry, I'm not gonna talk about this part because it's not much important. Or you can study it by yourself. It's not that big of a deal, honestly. So the insulin. What does the insulin do? Well, to know what the insulin do, we have to know the structure behind it. Like, what is it made of? Well, it's made of polypeptide connecting like it's made out of like two chains that is connected by a polypeptide. We're gonna talk about how it looks like in the next page here. Just keep that in mind. Linked by this disulfide bridge. So it's like two chains here connected by sulfide, I guess, links or whatever, uh, produced by the beta cells and transported to the Golgi apparatus when then into the plasma membrane. So I'm pretty sure you guys know what is the Golgi apparatus. You have like this nucleus. This is the cell, obviously. The nucleus. This is the Golgi apparatus. Like it's kind of like it's being produced from there and goes into the plasma membrane. Usually have half life of 5 minutes in the blood, and helps with storing glucose molecules inside the cell. Simple as that. How does it store the molecules inside the cell? We're gonna talk about this. Actually, I could just skip. Hold on. Made of several chains. Those chains are B, A, and C. We're gonna talk about those things in a minute. As develop as pro pre pro insulin. So it's pre pro insulin, pro insulin, and then insulin. We're gonna also talk about this. Can lower the hypokalemia here. It can make hypokalemia. Oh, sorry, hyperkalemia. It can increase. Sorry, it can decrease the potassium levels in the blood because it helps with storing the the potassium into the cells, which is used to treat hyperkalemia here situations. I'm gonna go a little bit further down just to like explain one part here. So this is the insulin here. Uh, I'm gonna. This is more of a like I guess histology, but at the same time physiology of how the insulin work. So this is the insulin molecules here. It kind of like binds into receptors of the cells here and triggers something here that we call the glucose transporters. So the glucose transporters kind of like when it senses the insulin binding into the cell wall here, cell wall here, I guess, uh, it moves into the cell wall and start putting their glucose transporters for the glucose to go inside the cell and start making, I guess, the energy in the mitochondria here. So this is uh, how the physiology of the insulin here work. More about the how the insulin is made here is like as we said before, it starts as pre pro insulin. Just remember it this way: pre pro insulin, pre pro insulin, and then pro insulin. We just removed pre, and then it's just like insulin. Simple as that. So what is pre-pro insulin? Pre-pro insulin here is mainly like has like a B chain, C chain, and A chain. Uh, Obviously sulfur bonds here. Uh, so I guess here single sequence. So it loses its single sequence here, as far as I remember. Uh, and as soon as it loses it, uh, its name changes into proinsulin. So proinsulin basically is the same thing but without the single sequence. But it also have like its I guess these its sulfur bonds here connected, so can prepare for like losing the C chain here. Uh, when it does lose its C chain, it's basically that's basically insulin here. So insulin is basically like B chain, uh, well whatever that is, A chain. This is A chain, and B chain connected by sulfur um, bonds here. So as we said before on the previous page here, makes several ABC helps with strong glucose. Uh, 5 minutes. Okay, apparatus. Yeah, as we said here, two chains of amino acids linked by disulfide bridges. So it's a disulfide bond connected, connecting the B and A chains, as we said before. Proinsulin is the starting point of the development of insulin in the cell, starting up with the chain losing the signal sequence, then uh, hearing its sulfur chain, hearing the sulfur chain bonded during uh, turning it into proinsulin. Okay, that's fair enough. Please make its insulin. Okay, I feel like it's that's like very self-explanatory. I already explained this. So how does the glucose reabsorption happen in GIT? So we have this. This is the lumen, right? And this is the epithelial cell, and this is the C endocrine. I don't remember what that is. I guess that's the blood. So basically, what happened is this is the glucose, right? It moves inside the blood or whatever. And what the insulin does, hmm, so what the insulin does, or the I guess the SG SGTI, that's like a transporter. It takes glucose inside the cell, right? The epithelial cell, but it also takes sodium with it inside, uh, while taking fluor, I guess. So glucose and fluor transporter always here. But for it to go inside the CEF, I'm not sure about. Like I can't remember uh, studying this on this. I haven't focused on this part. But uh, for like for sodium, sodium goes inside, and kalemia or potassium go outside using ATP here. Insulin lowers blood glucose by insulin lowers blood glucose by diffusing glucose into the cell. Pretty self-explanatory. Increases the storage of glucose into the liver. So how does that work? So uh, you know how like your body kind of like when you have too much glucose right in your body, uh, it ends up getting stored in your liver as glycogen, right? Glycogen is like basically like chains that are connected to each other like that. It helps with the storation. It mainly is stored in the liver and also the muscle. So it helps us with making glycogen inside the liver and muscle. So basically, what mainly the insulin does here, it lowers the glucose level, but it also lowers the sodium level. Not no, yeah. Sorry, I meant the potassium level or kalemia levels in the body. Helps with making glycogen inside the liver and muscle, as I said before. Decrease glucose output from the liver. So it decreases the glucose that goes outside the liver here. Insulin plus growth hormone is important for normal cell growth. This is very important, by the way. I remember like a question coming about this specific point here, so you need to memorize that. So factors that stimulates insulin secretion is basically literally like glucose. So the glucose that you consume, and obviously also glyco, I guess whatever that is, glucose that you're taking needs to be moderated. I guess controlled by the insulin. So the more glucose you take, the more insulin is gonna be produced. Simple as that. Glucagon, which is also the one from like the alpha cells, GIT hormones, amino acids, ketone bodies. Um, yeah, ketone bodies, by the way, comes from like breaking down fatty acids from amino acids, I guess, or whatever. We're gonna talk about this because it's like literally like a little syndrome that causes a lot of like problems like acidosis or whatever, called ketoacidosis, something like that. We're gonna talk about that later on. Stimulation drugs can also stimulation, but yeah, drugs can also have an effect here. So factors that inhibits insulin secretion can be high levels of somatostatin, uh, kalima, tepidation, exogenous insulin drug, symptomatic stimulation. Okay, I don't think that's very important. So glucagon is a polypeptide hormone, and is secreted by the alpha cells, as we said before. Half life of like 5 to 10 minutes in the blood can increase the glucose level in the blood, increases the metabolic rate. This is very important, by the way. Uh, it basically does the opposite of the insulin. You know how I said that the liver is affected by the insulin, where it's like it doesn't secrete as much glucose, and it doesn't make as much. It makes as much of like glycogen as possible. Well, glucagon here does the exact opposite, where it promotes the liver to excrete glucose and break down glycogen into glucose. Right? This is the liver, by the way, if you haven't, I guess, guessed. But anyways, you get the idea here. Can increase the metabolic rate, help us with secretion of growth hormone, factors that stimulates the secretion rate. I guess that's secretion, right? Secretion R, amino acid, amino acid cortisol, ARSH or ASH or whatever that is, hypoglycemia. Yeah, hypoglycemia is like one of the most important things, and cortisol as well. Hypoglycemia is like, yeah, you have low levels of glucose, so your body has to like break down the glycogen that is stored in your body, right? So what it does is it increases the uh, glucagon levels in your body from the alpha cells. Oh shit. So hyperglycemia. So hyperglycemia can inhibits the production of glucagon, but also stimulates insulin and I guess ketone bodies or whatever. Okay, so let's talk about the pathology here. Um, like I'm pretty sure like all of you guys, most of you guys know about the diabetes mellitus. It's literally diabetes, and it's basically like your body is not making enough insulin, if not at all, to the body, and this is caused by type 1 and type 2 diabetes. So basically, around like 10% of all the world is affected by the or sorry, like diagnosed. 10% is diagnosed with diabetes mellitus, right? Uh, and 1% of these of this 10%, no, sorry, 1% of those of this whole thing is like type 1 diabetes, as I said before, while the other 9% is type 2 diabetes. um Diagnose, like a glucose level. Okay, so let me just remove this real quick. So type 1 diabetes is caused by fourth type 4 hypersensitivity immune response, where the body's own T cells attacks the pancreas, killing the beta cells. So basically, there is like a resistance, right, against this whole like hypersensitivity reaction, and when there is like some sort of like genetic disorder that happens in the body, it kind of like makes those T cells attack specific cells in the body, and those cells are usually like the beta cells that produces insulin from the pancreas. Sorry. Anyways, so T cells lose half its self tolerance. Yeah, self tolerance is like basically, yeah, as I said before, loss of beta cells means loss of insulin, obviously. Beta cells decrease usually happens in early ages. So yeah, it usually happens in like early ages, where like children would be diagnosed with type 1 diabetes, but it does happen with adults as well. Uh, the symptoms doesn't appear until 90% of all the cells on the pancreas has been literally destroyed, necrotic, just gone. Simple as that. Only after that, the symptoms is gonna show up. What triggers something like that to happen? Nobody knows. Actually, that's like nobody, just nobody knows, I guess. Uh, Symptoms: polyuria, which is urination a lot. Uh, Glucosuria, glucose present in urine. Weight loss, hunger, and dehydration. Dehydration being like being thirsty, I guess. So diabetic ketoacidosis. This is like a complication of type 1 diabetes. It can develop a diabetic ketoacidosis. So ketoacidosis, what is ketoacidosis? So here's the thing. What happened is your body, like you have too much glucose in your body, right? Let me just, you have too much glucose, and like your body just can't use it, right? They're just like floating in your blood. It's basically useless, just like going back and forth to the heart, back and forth, like just doing absolutely nothing. It's not going inside the cell. It's useless. So what happened is your body has to like rely on something else. So what ends up happening is, which is like, which explained one of the symptoms here, which was the weight loss. Why do you think a diabetic patient would lose their weight? Well, the body has to break down the adipose tissues in the body to produce amino acids, and those amino acids become energy that the body can use. But here's the problem: what ends up happening is it increases the acidity of the blood, and when the acidity goes up and high, the keto bodies becomes so concentrated to the point that it develops into acidosis here. So as I said, in DKA, which is diabetic ketoacidosis, the body breaks down fat into free fatty acids, which is which is later used by the body to make energy for the cells in the form of ketone bodies, which can greatly increase the acidity of the blood. So how does that I actually already explained that. So another symptoms of like ketoacidosis here, diabetic ketoacidosis, is hyperkalemia. Why hyperkalemia? Well, here's the thing: uh, when you're breaking down too much ketone bodies, you're also releasing hydrogen plus or whatever. So hydrogen plus like goes inside the cell, right? And in trade of that, it takes off one kalemia or one potassium here, and this potassium ends up like building up in the blood, right? Causing hyperkalemia. So you would ask, okay, well, why can't the body get rid of it and put it inside the cell? Well, there is no insulin. Remember, type 1 diabetes. So when there is no insulin, then the body can't just put back the what do you call it, uh, the kalemia or the potassium here inside the blood for in the trade of like the sodium here. So if you don't know that already, like insulin trades off the potassium, the sodium goes outside. This is why I literally said it's being used to treat like hypo I mean hyperkalemia here. Can't remember where I posted. That doesn't remember. That doesn't, it's not important right now. But yeah, as I said, uh, insulin can put back the potassium, and sodium ends up like not going outside the body, right, in the blood. So you would assume, hey, isn't that supposed to mean that there should be like uh, low levels of sodium here? Well, like you would ask, how is sodium here is regulated and not like lost because it's all inside the cells? Well, here's the thing: when you have too much, I guess, potassium in the blood, that stimulates the adrenal gland on the adrenal cortex to produce aldosterone. So what does aldosterone is it helps with the reabsorption of sodium from the urine in the kidneys, right? When it does get reabsorbed, it regulates the sodium levels, which explains why that even with hyperkalemia, there is still our normal uh, blood sodium levels in the plasma here. So how do you treat something like that? Well, uh, if you have too much acid in your body, then you treat it with water, right? You have to hydrate the patient, like uh, I guess give them as much water as possible. And to treat like the hyperkalemia here, you have to give them insulin. As I said before, if there is insulin present in the blood, it gonna help like with the reducing the kalemia. But Yeah, obviously, and it helps with like glucose, but assuming like assuming that the patient is like suffering from some sort of like I guess hypoglycemia while this is happening, you could also provide them with like glucose with insulin at the same time. So moving on to the type 2 diabetes. So what is type 2 diabetes? It's basically just like type 1, except it's not fully like your body is still like producing insulin. Like it's basically like your body is still producing insulin, but it's either like not effective or it's just like not enough for your body to like maintain or whatever. So by definition, the pancreas makes insulin, but the body does not respond, right? So hyper, let me say, okay, so what ends up happening is this is the normal cell here. The insulin goes inside the receptors, activates, binds into it, obviously, activates the glucose transporter, moves onto the cell wall, and lets the glucose go inside. See, it's kind of happy. That's a smiley face. Anyways, but in type 2 diabetes, what ends up happening is insulin is binds into the like receptors, right? But for some unknown reason, the glucose transporter just like says nope, I'm not gonna do it, and doesn't like go for the I guess the cell wall here. So what ends up happening is the glucose can go inside the cell, right? It can't just pass through it. It needs the thing here, the the the, the, glu, the the glucose transporter, right? So it's just gonna like deflect. It's gonna be sad like that. So why does it happen here? Well, it's mainly caused because of obesity, hypertension, lack of exercise. It could also be genetic or just basically high sugar intake here. But how? Well, nobody knows. That's the thing. But there is some speculations where obesity is like, well, you have so much like adipose tissue, right? And you have to supply it with, I guess, insulin. And what ends up happening is your pancreas can't produce enough insulin to meet your body's needs. And there's like a small speculation, but I don't think they're gonna bring it up on the I guess the whatever the hell is the, the exam or whatever. So yeah, let me check here. Hyper stimulating oxygen, like high levels of plasma osmolarity from high concentration of hypertension. Water follows glucose. Oh yeah. So in the case of like high levels of glucose in your body, it's kind of like there are two things that, as far as I know, actually, there are two things that kind of like the water follows H2O, follows all the time, which is uh, hold on, oopsies. So this is H2O. Um, it follows two molecules, which is the glucose and the sodium. And so whenever there is like that's like uh, a rule in the human body. Whenever there is too much of those in the body or inside the cell or outside the cell or like on the urine, what ends up happening is the water ends up like following that. And so when you have too much glucose in your body like that, all the fluid inside these cells are gonna end up go leaving the cell and going to the body. And so what ends up happening is you have too much fluid in your body. So it ends up making you have too much urination. So high glucose means high H2O in the blood polyuria, and polyuria can cause dehydration. Dehydration can even develop into mental status change, acidosis, and some other stuff here. Um, all right, this is mainly for type 2 diabetes. So for the third type here, just I'm not gonna even try to attempt saying that, so I'm just gonna call it GDM for short. So GDM, what is GDM? It's basically another type of diabetes it's basically similar to type 2 diabetes, but what makes it different is the fact that it only happens with pregnant women, right? So assuming like the women doesn't have like a past medical history or diagnosis of like I guess type 2 or type 1 diabetes, and this just like came all of a sudden, then that's GDM diabetes here, sorry. But it can develop later into type 2 diabetes. Uh, the causes is mainly unknown here, but it's diagnosed in the second and third trimester here. So for the diagnosis, so you want to like diagnose a diabetic patient. You could try something like a fasting test, which basically like you like don't let the patient like eat or drink except well, obviously water here, anything for 8 hours, 8 hours straight, right? Uh, and just after that, you just like test their blood glucose, and if it turns 10, I'm sorry, 100 to like 125 milligrams per decibel, that's pre-diabetes. But if it's more than or equals 126, then that's basically just diabetes. There is also the regular one or the non-fasting one, just like the random one that everyone takes. If it's more than or equal to 100 milligrams, sorry, then that's basically like a red flag for diabetes. While glucose oral test, which is basically like they give you like glucose in your mouth, like in your tongue, right? And just leave it there for 2 hours, and after 2 hours they just like test your blood sugar levels, and if it's like 140 to 199, that's pre-diabetes, and if it's more than or equal to 100 milligrams per decibel, then that's just basically diabetes. So what are the risk factors here? So risk factors, you have like too much glucose in your body. For the long run, it's gonna like it can rupture the arteries and arterioles in your body, because it's kind of like uh, the glucose molecule just like move and like hit the walls of the arteries and rupture it, which can uh, even like develop into embolism and thrombosis. It can cause heart attacks. It can cause some other stuff that I don't remember actually. So weakness of sight. I don't remember the physiology behind this, so you're gonna have to like look for that by yourself. Nephrotic syndrome. So how does it affect the nephrotic syndrome? Well, here is the thing. So obviously, if you still remember the urinary system here, you have the glomerulus, right? This is the glomerulus, the efferent, the efferent. So this is the efferent here. It's gonna be something like this. You have too much glucose here, right? And it kind of like builds up in the walls here, which narrows the blood supply into the glomerulus from the afferent part here, uh, which is bad. Why is that? Because the less blood here, then the less filtration, and the less filtration is gonna like uh, decrease the urine output. It kind of like damages the granulus in one way or another. I don't exactly know the details behind it, simply because I don't remember it, but it mainly can cause nephrotic syndrome, which is urinary thing. So it can also decrease sensation, like when you feel like the feeling of your like nerves, like in your fingers and nail and like your toes or whatever. uh, you kind of like tend to like lose the sensation of these parts of your body, and it could even like stop some functions like blood supply or whatever, and you might just get your limbs amputated just for that cause. um, so how do you treat that? Type 1 diabetes, sorry, but it has to be insulin here. uh, but for type 2 diabetes, uh, it's mainly like you have to lose weight, exercise, healthy diet, and take anti-diabetic meds here. And if that doesn't all work, then insulin should be like the main, I guess, medicine that you should be, or the treatment, I should say, that helps with the I guess, uh, the treatment here. Uh, So yeah, that's basically it. Oh, and by the way, this video isn't sponsored by Cam Scanner thing or whatever. It's just like there because I took, I guess, pictures. But yeah, that's pretty much it about the pancreas. I hope you guys, well, enjoyed, I guess. uh, I hope that was helpful, and yeah, have a good one.